مساء الخير جميعا. فرصة ان انا اكون مع حضراتكم النهارده، وانا سعيده قوي ان انا ابقى في التجمع ده بالهدف بتاع increasing awareness about human papillomavirus vaccine. It is my honor and my pleasure to present the first speaker, Professor Dr. Mary Lomsden. Professor Mary is the professor of medical education and gynecology in the University of Glasgow and the immediate past CEO of the International Federation of Gynecology and Obstetrics. And we are very much looking forward to hear her talk about HPV and cervical cancer. What did we achieve worldwide? So, Dr. Marianne.
Okay, if I stand in front of the slides, just shout at me, please, because I think it's important that people can see them. I'm going to talk about cervical cancer as a public health problem, rather than just as a medical issue or as something that interests a few people. We need to get it better known. I've been interested actually in talking to a number of people here, that there are quite a number here who knew absolutely nothing about HPV and cervical cancer. So I think something really has been achieved today. Now, this was what was said in 2020, which started off the WHO drive to eliminate cervical cancer. And over the next 12 years, by 2030, the annual number of new cases will increase from 570,000 to 700,000. And during the same period, the deaths will increase to 400,000. That's an awful lot of deaths. 85% of those are in poor countries. And this is a real disgrace. And so this led to the World Health Organization document, which defined the 90-70-90, and which is being closely followed by a number of organizations and those working in the area. And so, right, now this is the first little issue I think we need to think about. Okay, it may be that it's more than 2 or 4 or 6%, but it's little doubt that Egypt is at the bottom of the league table for Africa, i.e. it has less cervical cancer. However, something that is quite noticeable is that it appears that an awful lot, a big proportion of these women are going to die. And so this is not just as straightforward as you might think it is. And also, I think in the UK, postpartum hemorrhage, for example, death from postpartum hemorrhage is pretty unusual. But does it make it less significant? No, it doesn't. And so I think we've got to sort of move a little bit away from numbers and look at the significance, as I tried to show in my earlier talk. Now, we talked a lot about different HPV types, which I think is quite important. One, because I don't know, and somebody maybe can tell me, about how rapidly these subtypes will mutate, possibly not very rapidly, and whether there will be more that will come along. But basically, the HPV vaccination programs are very successful. We've heard that, fortunately, there are only 2 that cause 70% of the cases. We've got good vaccines against them. But here is problem number 1, and that is the cost of vaccines. And so we have this wonderful monovalent vaccine, which will prevent 90% of cancers. But a lot of people cannot afford it. Now, for those who don't know much about Gavi, which is the Vaccine Alliance, WHO, Gates, UNICEF, and 1 or 2 other organizations, where they provide free vaccine to lower income countries. Now, this sounds fantastic, which it is, but they don't provide money to deliver the vaccines to where they need to be used. And there are all sorts of issues with delivery because it also has to be refrigerated. So things that one needs to think about as somebody interested in public health. And we do know that those that have achieved high vaccination coverage have had declines of up to 85% in prevalence and nearly 60% of high-grade lesions. Now, I'm sorry that I'm only talking about girls. I feel very guilty now, but I don't know much about men. And oops, sorry. Oh, right. Yes, what's happened here is that we should be able to reduce the median age standardized cervical cancer incidence from nearly 20 cases per 100,000 women to by about 89%, sorry. Is this microphone sounding as bad to you as it is to me? Oh, it's not. Can you hear me all right? You can. Okay. It's sort of echoing in my ears, which is no good. And we should be able to avert 61 million cases, which is no mean achievement. So, right, let's think about screening methods. And we've heard a bit about it, but let's start at the beginning. How do you, as a public health physician, set up a screening program? You look at your target population, the test you're going to use, how often, triaging diagnosis, treatment, follow-up care, evaluation of program impact, quality assurance. Not entirely straightforward, I think. And this has been the problem because some of the programs set up haven't managed to achieve this, and it's very difficult to know how successful they are. Because the screening method must be matched with resources. And I think sometimes people hear about these wonderful new things that can be used to identify HPV, to screen, and they think, fantastic, but it is well out of the reach of many countries. Now, screening, as you all know, I think now, cervical cytology, the old-fashioned cervical smear, visual inspection, HPV testing, which I'll mention a little bit more about, and organized programs versus unorganized programs. And I think for follow-up, the only program that you can really do is an organized one. Otherwise, you don't follow up the patient, and there's nothing worse than screening and then not following up. Now, with the HPV testing, it is possible to do it. WHO recommend it, but the machinery to do it on is quite expensive. It requires a technician to be able to run it. These technicians, once they've been trained up, are apt to go somewhere else where they get paid more money, I'm told, by one or two people. Not particularly here, but in other countries. And you need a technician to deal with it when it breaks down and know who is responsible. So all these things must be thought through. Now, I've put down some information about how we assess screening tests. And the sensitivity is how good it is at picking out what you're trying to measure and how specific it is. And then you've got the characteristics of it. This was the tried and tested, but it needs a healthcare infrastructure because it has to be done by healthcare personnel. It can't just be left to anybody else. The HPV DNA has very high sensitivity and moderate specificity, and it's laboratory based. So the real advantage, I shouldn't have started with the disadvantages, I should have started with advantages. is that you can get a huge throughput once you've got the samples, and then you've got these visual inspection methods, which are not terribly specific, and they're not hugely sensitive, but they're pretty good, and you don't need much technology. And you can link with immediate treatment, and this is a really important point. If you have somebody who has walked 40 miles to your clinic for a test, they're not going to walk back and then come back to your clinic again 2 weeks later. So whatever you do, as far as possible, you need to do it quickly. Now, HPV studies have been going on. There have been some quite good studies over the years. This is one, an RCT, which is relatively unusual. HPV plus cytology versus cytology alone. And it was found that the primary HPV testing with cytology, i.e. test for HPV, if it's there, you then do a smear. And that tends to be now where people are moving towards. And it decreases the need for more invasive investigation, which is good for everybody. Now, in the United Kingdom, we really, it's not a disastrously high. 3,000 women a year get cervical cancer, but 75% it'll be early. And a lot of these later cases, unfortunately, occur in refugees and those coming from outside who haven't accessed healthcare. And 20 to 40% are detected in specimens from this loop cone. And if you remember the earlier presentation, when there was quite a nice illustration of a loop cone of the cervix, so I haven't included a picture of that. Now, all women can go, and they are called and given appointments to go for screening between the age of 25 and 64, and they go every 3 to 5 years. It's changed a little bit because now that they check for HPV 16 and 18, if it's present, immediate cytological checking and maybe further investigation. If it's absent, bye-bye, they go away for at least 5 years, and it is likely that some will not be screened again. So the thing about screening is it is a balance between doing good and preventing harm. And minor abnormalities, as we know, can regress with time. And we know even with severe abnormalities, 40 or 50% won't get cancer. So there's a risk of over-treatment because treatment has complications. And I can remember back in the mists of time when I was a junior doctor doing cone biopsies, particularly to get a disease that was really up in the canal of the neck of the womb, the cervix. And it was quite a challenging thing to do on some occasions. And it led, hopefully not in my hands, but overall, into an increase in, loop cone biopsy, in increase in preterm labour. And this is true with a loop cone, which is really quite superficial. So think about it carefully before you embark on these things. Now, I've got some Scottish figures. Of course, I've got some Scottish figures. I worked in the NHS in Glasgow for 35 years. The paper is from Glasgow and Edinburgh. But it shows actually something which is not intuitive. And that is, I'm sorry you can't see this clearly, but it shows that the incidence in the white women is actually higher than in the black and Asian women, which is an unusual way round. But we're not certain of the reasons for that in many instances. And you can see the impact of screening that there's been. The incredible decrease, and this is shown better in this slide, which I think is the one Amal showed earlier on, which with the increase in screening and treatment, you've got very, very low levels. But the downside being that a lot of these cases are occurring in the very disadvantaged women who are hard to reach. So we don't do under 25s, it's not worthwhile. And I thought, well, let's see what's happening in Arab countries. And there's a low screening uptake of about 18.2%. And the reasons appear to be the following. People just don't know about it. They fear it. They feel perfectly well, as we were hearing about earlier on. And they're embarrassed. And they don't want to have to go and have this ordeal. And so we've got to link our screening, diagnosis, and treatment if we're going to be successful. Now, in the high resource settings, you get this. You have your initial screen, you have your colposcopy and investigation, you get your treatment, and then you get follow-ups. So endless visits to a healthcare facility. But in low resource settings, you need to screen and treat. You can't have all these visits. So this is what we have to aim at. And I think we're now all aiming at it in the NHS in the UK. But this new DNA screening, although I was a little bit negative earlier, is a huge advance. It's easy, no need for cytologists, all done on machines, and patients can collect their own specimens. And this is really important. And the FDA have approved self-sampling, although they like it done in healthcare settings, which seems to be counterintuitive, but it is helping. So I think we need to try and get more self-collection, more knowledge into the hard-to-reach populations. These are the ones that are being missed out. It needs robust lab and communication infrastructure. And somebody mentioned in one of the talks about the importance of management. And I thought, that's something I've missed out before. But it is, it's got to all be joined up. And we have to assure follow-up. And that's the most difficult thing. So I won't go through those again. These are things which different countries have to fight. They each have their own difficulties, and you have certain ones and others have others. I don't know what the child marriage rate in Egypt is, but in some countries, for example, in Bangladesh, Pakistan, it's really quite high, and that's we find staggering in the West. And so when you get both together, you can avert deaths, and these are in high-risk countries, by using screening and treating and vaccination. So I think that, there is hope if we can get the screen-positive women sorted out properly. So we want the single visit, and you can do all sorts of different things, colposcopy-directed biopsies, but you need skilled staff to do colposcopy. It's not just something, although people say, oh, it's easy peasy doing visual inspection. It's not always. And so a certain amount of training is needed. And I think all this information's been there before as to what we're trying to achieve. Now, I thought another, South America. This is a country in a disadvantaged population. 22,000 women, 2,860 were HPV positive. And then these were followed up appropriately. 251 of 281 CIN2+ women received treatment. Now that, to me, is success. High proportion of women receiving treatment who wouldn't have done otherwise. And so I think these are the sort of outcomes we need to measure and look for. Now, these slides I got from Dr. Richard Godfrey, who is involved in our sort of cervical cancer network in Rotary, talking about self-screening, and where you do the self-sample, and then you use very, very simple equipment, which is all portable, to do the assessment for DNA. And it's apparently making life a lot easier. You don't need great, big, complicated machinery. And this, I think, is a rather nice little image which shows what you can do with self-sampling. You can do it in a way where there's transportation without liquids, has to be an advantage, wonderful for remote sites, great for community screening, and it's cost efficient. And so all these things are very successful in trying to get to the disadvantaged populations. And they're doing very well in South America overall. The basic lab. Now, $30,000 is cheap, I think, in anybody's money. And you can get a basic lab where you can use the equipment that I've just mentioned. And then, if you have somebody, if you don't like what you're seeing, or you've got a positive result, you can use these handheld equipments. These worry me a bit, actually, as a gynecologist, but I'm assured that they are safe, reliable, and don't have a lot of nasty complications. And it causes necrosis of the tissues of the neck of the womb, the cervix, sorry, and doesn't involve any surgical management. So it can be done by people with very little skill. That also worries me a bit. But all these things are being tried and evaluated, and I think that's very positive. I would love to stop showing this slide because I'm fed up with it. I want it to change. I want the mortality to come down and these dark red areas to disappear. So we need to be thinking, how can one make this successful? I talked in the earlier part of the day about advocacy and how can we get all this across to the public, to government, to people who matter. And these are various ideas that people have employed using the lay public, people who have experienced the different treatments and problems, and giving evidence-based information about cervical cancer, correct information, as we know from the evidence base of the moment. And it gives hope when people can see somebody like them who's been treated and got better. It gives hope. And so I think this is an important start, which can be done with the general public. Now, I think one of the important things, and we did discuss this recently on a webinar we had through Rotary, was how important it is to have involvement of the health department and the government in ensuring the continuity of a program. Otherwise, it makes it very difficult because the money will run out. And so what can one do? And this is where you need to be able to advocate to officials. And this is not easy for a lot of people. When I was at FIGO, the International Federation of Gynae and Obstetrics, we managed to work with the Gates Foundation to get a project funded where we were trying to enable and improve female doctors' ability to advocate and to persuade government officials to do what they wanted them to. And so it's still ongoing and is successful in some places more than others, inevitably. But advocacy can lead to policy change even when it's done through the community, the aim being getting the community to help you reach those who matter. HIV/AIDS in the 80s. I think we can all remember that. FDA changed clinical trial policy with the trial of an HIV drug. Pricing changed. Breast cancer advocacy. That's changed dramatically, and the stigma has gone. And so hopefully one can do the same with cervical cancer. And then the polio elimination campaign, which is where this is arising from. So I think there are examples where advocacy really works. And I think it's going to be something that gets more and more important as one knows what works and doesn't, and is able to do the vaccination and the screening, and it must be kept going. And so that's all I wanted to say. Thank you. And thank you for having me. It's been a very interesting day.
Thank you, Dr. Mary, for very nice presentation. If in the floor there is any question for Dr. Mary or comment, تفضلي دكتورة ماري.
The Gavi delivery, you are right, the Gavi provide the vaccine free in low-income countries, but recently they changed policy and they allocate 13% of the budget given to the vaccine by the government must give to CSOs and NGOs to work on the awareness and delivery. So now there is change of policy in the Gavi because they appreciate what you have said, that the vaccine is there, but the uptake is still low.
Yes, I think that's absolutely right. And in somewhere like Malawi, apparently one of the big problems they were running into was that the vaccine was going out of date before it could be delivered. And so we've been discussing with them the potential maybe for funding or getting Rotary to fund a project for delivery and see if one can help there. The other thing that struck me is that some of the lower middle income countries run into problems, particularly if they go from being a lower income to lower middle income, because they lose the Gavi funding. And Gavi, of course, has lost a lot of American funding. So it's a complicated situation, but I think, you know, we have to keep at it, is the bottom line. Mustn't give up. So.
Okay. Thank you, Dr. Mary. Any question more? You need comment? But very short comment because of time.
That Pakistan and Bangladesh high rate, to my knowledge, is India, whole Indian subcontinent. Yes, you mentioned that I'm just reconsider your work in this way. Again, in Western Africa, this is, I would say, is a dominant there. I'd like to say. Egypt, however, you said is a lower league of that. I appreciate that. However, it is not very well documented. And the initiative by the Rotary, I have to admit, it is one of the best I ever seen. Yes, you know, as you are UK as well, I am UK as well. You know that local or NGO, as she mentioned, my colleague here, initiate every work. But here I'm afraid most of the Egyptians, what they call, waiting for the spoon feeding of the government, which is not nice. Thank you so much.
Thank you, Doctor, for your very precious comment.
Yeah.
Now,
can I just respond to that very, very quickly?
Of course.
I think you've raised a very interesting point to which I do not know the answer. But India is very interesting. They have patchy success in different parts, but it's now part of the national screening program. And it looks as if it will really, really improve. I mean, it's a very big country, a lot of cases. But
thank you very much for a very nice comment for Dr. Mary.